Hello everyone, I'm Dr. Eve Raisa Catalbas, a first-year student of the Master of Science in Health Informatics program of the UP Manila College of Medicine. For this lecture, I will be talking about Health Level 7. Health Level 7 is a set of international standards for transfer of clinical and administrative data between software applications used by various healthcare providers. It does not provide any sort of software. Instead, it gives healthcare organizations specifications for making their systems interoperable. The word that you have to remember for Health Level 7 is framework. What does HL7 mean? Level 7 refers to the seventh level of the Open Systems Interconnection Model, or the application level. The application level interfaces directly to and performs common application services for the application processes. Next, we will be discussing the organization responsible for Health Level 7. Health Level 7 International is a non-profit American National Standards Institute accredited standards developing organization. It is dedicated to providing a comprehensive framework and related standards for the exchange, integration, sharing, and retrieval of electronic health information that supports clinical practice and management, delivery, evaluation of health services. Since HL7 provides a framework or a set of standards, it enables interoperability. We have different kinds of interoperability. One is technical, which is moving data from System A to System B. Semantic, which is ensuring that System A and System B understand the data in the same way. And process, which enables business processes at organizations housing System A and System B to work together. Interoperability allows for meaningful transfer of information between two information systems. In the healthcare setting, this can translate to the following. First, it has a good impact on the safety, effectiveness, and cost of healthcare by having the right information at the right place at the right time. Second, it allows for presentation of accurate healthcare information at the point of treatment. And finally, it decreases the cost of transferring paper records, especially in this age of e-commerce. Before we go any further, let us review the timeline of the development of HL7. The HL7 protocol dates back to the late 1970s when its precursor was developed at University of California at San Francisco, or UCSF, Medical Center, and first implemented in production in 1981. In 1987, an international community of healthcare subject matter experts and information scientists collaborated to create the HL7 standard for the exchange, management, and integration of electronic healthcare information. Version 1 was announced in 1988. However, it didn't gain much traction. Version 2, also known as Pipe Hat, was originally created in 1989. Its aim was to support hospital workflows. Both version 1 and the first version 2 were essentially refinements of the UCSF protocol. They were solely used as desk standards with a couple of pilot tests. It wasn't until the end of 1990 when the first viable HL7 version 2 standard, version 2.1, was completed and published. Since then, the standard has been updated regularly, resulting in versions 2.1, 2.2, and so on. It is important to note that all version 2 standards are backwards compatible with earlier versions because the version 2 standard allows applications to ignore message elements they do not expect. This means that an older application can receive and process messages from newer applications using newer HL7 versions. The HL7 version 3 standard was first released in 2005 and was strongly influenced by the government and medical information users rather than clinical interface specialists. It was created to address some specific challenges identified in the HL7 version 2 standard, including the following. Number 1, an implied rather than consistent data model. Number 2, an absence of formal methodologies with data modeling, creating inconsistencies and difficulties in understanding. Number 3, a lack of well-defined roles and applications and messages used in difficult functions. And number 4, too much flexibility and not enough of a full solution. The version 3 Normative editions provide a single source that allows implementers of version 3 specifications to work with the full set of messages, data types, and terminologies needed to build a complete implementation. The HL7 standards are grouped into reference categories, and I will be discussing them briefly. The primary standards are considered the most popular standards integral for system integrations, interoperability, and compliance. The most frequently used and in-demand standards are in this category. Examples under this category will be discussed in the next slides. Foundational standards, on the other hand, define the fundamental tools and building blocks used to build the standards and the technology infrastructure that implementers of HL7 standards must manage. Third category is the clinical and administrative domains. Messaging and document standards for clinical specialties and groups are found in this section. These standards are usually implemented once primary standards for the organization are in place. Next category is EHR profiles, which are standards that provide functional models and profiles that enable the constructs for management of electronic health records. Another category is implementation guides, which is for implementation guides and/or support documents created to be used in conjunction with an existing standard. All documents in this section serve as supplemental material for a parent standard. We then have the sixth, rules and references, which are technical specifications, programming structures, and guidelines for software and standards development. Finally, we have education and awareness. This is where one can find HL7's draft standards for trial use and current projects, as well as helpful resources and tools to further supplement understanding and adoption of HL7 standards. Because the primary standards are the most in demand and most widely used, they will be the ones I will be discussing. So version 2 and 3 messaging standards are both primary standards for HL7. They are an interoperability specification for health and medical transactions. The version 2 messaging standard is the workhorse of electronic data exchange in the clinical domain. It is arguably the most widely implemented standard for healthcare in the world. It allows for exchange of clinical data between systems, and it is designed to support a central patient care system as well as a more distributed environment where data resides in departmental systems. One of the advantages of version 2 is that it offers a lot of optionality and therefore flexibility. However, this same feature contributes to an inability to support reliable conformance testing. It also requires implementers to spend more time analyzing and planning their interfaces to ensure that both parties are using the same optional features. It is one of the reasons why version 3 was created. Version 3 provides a single source that allows implementers of version 3 specifications to work with the full set of messages, data types, and terminologies needed to build a complete implementation. Its primary goal is to offer a standard that is definite and testable and provide the ability to certify vendors' conformance. Other examples of primary standards are as follows. We have the Clinical Document Architecture or the CDA, which is an exchange model for clinical documents based on the HL7 version 3. It is a document markup standard that specifies the structure and semantics of clinical documents for the purpose of exchange between healthcare providers and patients. The CDA can contain any type of document, and an example would be the discharge summary, the imaging report, admission and physical, the pathology report, etc. Its most recent version is Release 2. Another example of primary standard is the Continuity of Care Document or the CCD. It is a US specification for the exchange of medical summaries based on CDA. It is an implementation guide for sharing Continuity of Care Record or CCR, patient summary data using HL7 version 3 CDA Release 2. We also have the Structured Product Labeling or SPL, which is the published information that accompanies a medicine based on HL7 version 3. Its other names are as follows: product label, package insert, prescribing information, product information, medicines information, and others. Finally, we have the Clinical Context Object Workgroup or the CCOW. It is an interoperability specification for the visual integration of user applications. It is a standard for both internal applications programming and runtime environment infrastructure, and it serves as the basis for ensuring secure and consistent access to patient information from heterogeneous sources. Now we go to the fun part and the challenging part, which is decoding HL7. An HL7 message is a hierarchical structure associated with a trigger event. The HL7 standard defines trigger event as an event in the real world of healthcare that creates the need for data to flow among systems. Each trigger event is associated with an abstract message that defines the type of data that the message needs to support the trigger event. The abstract message is a collection of segments and includes the rules of repetition and inclusion for those segments. For example, a trigger event will prompt System A to send an HL7 message through the network into System B. System B will then be receiving the HL7 message, and upon processing, will send HL7 acknowledgement through the network to System A. And then System A will then receive the HL7 acknowledgement message. So the HL7 message is a unit of data transferred between systems. It consists of a group of segments in a defined sequence. Segments, on the other hand, are logical grouping of data fields. It is identified by unique 3-character codes known as segment IDs. And then we have the data fields, which are a string of characters that contain information related to patient encounter or event. One of the most important segments is the message header segment or the MSH. It is present in every HL7 message type and defines the message's source, purpose, destination, and certain syntax specifics. It is always the first segment in the HL7 message, with the only exception being HL7 batch messages. It contains 19 fields, 6 of which are required for all messages processed using the HL7 standards. So here is a table depicting the 6 fields that are required for the processing of messages using the HL7 standard. The first 2 fields in the MSH segment define the separator characters to be used throughout the messages, and they are MSH1 and MSH2. MSH9, or the message type, is the most important of the MSH fields. It specifies what type of message is being transmitted and what the trigger event is. MSH10, or the message control ID, is a number or other unique identifier for the message. MSH11, or the processing ID, specifies the HL7 processing ID or processing mode, and MSH12, or version ID, is the HL7 version used in the message, and it allows the receiving system to select the appropriate HL7 version to interpret the message. In this slide are the delimiters or separator characters. These delimiters or field characters are what you will see in MSH 1 and 2, which was discussed in the previous slide. It is important to note that the carriage return is a segment separator, and this is a standard which cannot be modified. However, the rest of the delimiters can be changed. So we have the field separator or the pipe, component separator or the hat, field repeat separator, escape character, and subcomponent separator. To apply what we have learned in the previous slides, I will show you a sample message. So this one is an ADT message or an admit discharge transfer message. ADTs are extremely common in HL7 processing. They are among the most widely used of all message types, and they communicate patient demographic and visit information, as well as the reason why the message is being sent or the trigger event. It has 51 different types, However, the most common are the ones on the table on the right. On the slide is an example of a patient admit message in the pipe and hat format. On the first line is the message segment header identified by the 3-character code MSH. The way you know that this is a patient admission is by the ADT code A01 encircled in orange. Patient admission is likewise the trigger event. Other important segments include PID or the patient identification segment, PV1 or the patient visit segment, and IN1 and IN2, the insurance segments. The PID segment is where you will find the patient's name and contact information. In this case, the patient's name is John Jones and his address is 123 West Street, Denver, Colorado. PV1, on the other hand, holds visit information such as attending physician and assigned patient location. So in this case, the doctor is John Quaker. And finally, IN1 and IN2 segments are where you will find the patient's primary and secondary insurance information. To further illustrate HL7, I will give you another sample message. Here we have an order message or ORM. It is a message that is used to transmit an information about an order. An order is defined as a request for service that is sent between applications or within a single application. Along with ADT messages, ORMs are also one of the widely used messages. In contrast to ADT, however, order message has only one type, which is ORM 001. Trigger events involve changes to an order, such as new orders, cancellations, information updates, discontinuation, etc. So on the slide is an example of an ORM in pipe and hat format. Similar to the ADT message, you will see the MSH on the first line, and then you also have the PID. The PID segment in ORM is only required if there is a new order and only if the new order is related to a particular patient. If these conditions are not met, then the PID segment will not be included in the message. So you also have the patient visit segment, and then you have the ORC or common order and the OBR or observation request, both of which are required segments in ORM. There are other segments which can be found in an ORM, but I will no longer be discussing them here. What about licensing, distribution, and cost? HL7 is licensing the use of most of its intellectual property at no cost. This includes the following. Number 1, standards that have already received ANSI approval. Number 2, published implementation guides and profiles. 3, published domain analysis models. And the last, current draft standards for trial use. All the standards can be found on their website. To participate, all users have to complete a click-through license registration process. If you go to their website, you will see that they encourage you to still avail of a membership. There are actually 3 types, including individual, organizational, and student. So why do you need to become a member if the IP is available at no cost? The most important reason for signing up for membership is the engagement in the development of standards. Members also receive the standards 3 months in advance compared to non-members. Additional benefits include, but are not limited to, free or discounted rates for trainings, certification of products for HL7 compliance, certification of advanced HL7 expertise for teaching or consulting, and help desk access. What about in the local setting? We actually have Health Level 7 Philippines, which is the official affiliate organization to HL7 International in the Philippines. It was officially recognized in mid-2004, and it fully supports the vision and mission of HL7 International. So that is my last slide, and these are my references. If you have any questions, hit me up in the comment section down below. And before you leave, do not forget to hit the like button and maybe subscribe so that you will be notified once I upload more lectures about health informatics. Again, I'm Dr. Eve Calbas and thank you for watching my lecture.